Hi everyone and welcome to my channel with PB. This video of mine is about premature rupture of membranes, which is basically of two types. In the first type, the rupture of fetal membranes occurs at least 1 hour prior to the onset of labor, that is at around 37 weeks of gestation. It occurs in 10 to 15% of term pregnancies, and it is associated with minimal risk to the mother and fetus due to the advanced gestation. The second type is preterm premature rupture of membranes, that is PPROM. In this, the rupture of fetal membranes occurs before 37 week of the gestation. Okay, it complicates around 2% of pregnancies and it has higher rates of maternal and fetal complications. It is associated with 40% of preterm deliveries. And earlier I posted a short video about this premature rupture of membrane on this channel, and today I am going to discuss this illness in detail. First of all, let me tell you the etiology and how the process starts. Well, the fetal membranes consist of the chorion and the amnion. They are strengthened by collagen and under normal circumstances become weaker at term in preparation for labor. The physiological process underlying this weakening includes apoptosis and collagen breakdown by enzymes. In case of premature rupture of membrane and preterm premature rupture of membrane, a combination of factors can lead to the early weakening and rupture of fetal membranes. Early activation of normal physiological processes are higher than normal levels of apoptotic markers and MPs in the amniotic fluid. Okay, and then the other thing is inflammatory markers which are cytokines contribute to the weakening of fetal membranes. Approximately 1/3 of women with PPROM have positive amniotic fluid cultures. Okay, and third is genetic predisposition. Okay, and now I'll tell you the risk factor. The risk factor for premature rupture of membranes and preterm premature rupture of membranes are smoking. I mean, if a lady is smoking before 28th weeks of gestation, also if there is a previous history, of premature rupture of membranes, if there is a vaginal bleeding during pregnancy, then if there is a lower genital tract infection, that can also lead to PROM. Okay, if there is some invasive procedures such as amniocentesis, and if the woman is having polyarrhythmias in which there is excessive amniotic fluid. Well, earlier on this channel I have already posted a video about polyarrhythmias. That is very informative video. You can see that video in this channel. The link will appear in I button. Okay, also if somebody is having multiple pregnancy and if there is a cervical insufficiency, that can also lead to premature rupture of membranes. Okay, now I'll discuss the symptoms. In premature rupture of membranes, a typical history is of broken waters, with women experiencing a painless popping sensation followed by a gush of watery fluid leaking from the vagina. However, the symptoms can often be more non-specific, such as gradual leakage of watery fluid from vagina and damp underwear or pad, or a change in the color or consistency of vaginal discharge. On speculum examination, fluid draining from the cervix and pooling in the posterior vaginal fornix may be seen. To ensure an adequate examination, the woman should be laid on an examination couch for at least 30 minutes. This will allow pooling of any leaking amniotic fluid in the top of the vagina. Additionally, a lack of normal vaginal discharge can be suggestive of premature rupture of membranes. Asking the woman to cough during the examination can cause amniotic fluid to be expelled. A speculum is not required if amniotic fluid is seen draining from the vagina. Here I want to emphasize one thing. In women with suspected premature rupture of membranes or PPROM, it is important to avoid performing digital vaginal examination until the woman is in active labor. This is because it has been shown that digital examination reduces the time between the rupture of membrane and the onset of labor. This is likely due to the increased risk of introducing an ascending intrauterine infection. Okay, Now I'll tell you about the investigations. A diagnosis of PROM or PPROM is usually made by maternal history of membrane rupture and positive examination findings. Ultrasound is not used routinely but may facilitate diagnosis in cases which it remains unclear. A reduced level of amniotic fluid within the uterus are more suggestive of membrane rupture. In all cases of premature rupture of membranes, a high vaginal swab should be taken. It may grow groups B streptococcus, which would indicate antibiotics in labor, or give information as to a potential cause for premature rupture of membranes. Usually, bacterial vaginosis is commonly implicated. Okay. Other tests include Furning test, placing cervical secretion into a glass slide and allowing it to dry, forming phone pattern crystal if there is a premature rupture of membranes. The false positive rate is around 6%. Then there are some other tests like active PROM Amniotic test. No need to go into the details. Okay. And then there is a nitrazine testing, that is a high pH of amniotic fluid that also sometimes gives false positive. Now I'll discuss the management. A rupture of the fetal membrane releases amniotic fluid which acts to stimulate the uterus. Therefore, the vast majority of women with rupture of membrane will fall into labor within 24 to 48 hours. There is very little that can be done to halt this. If labor does not start, it is important to consider the risks and benefit of expectant management versus induction of labor when formulating an appropriate management plan for women with PROM. If the pregnancy is of less than 34 weeks of gestation, the balance would normally be in favor of aiming for increased gestational period. If it is more than 36 or 37 weeks of gestation, if labor does not start, the induction of labor should be considered at 24 hours, 24 to 48 hours. This is because the risk of infection outweighs any benefit of the fetus remaining in uterus. If it is between 34 to 37 weeks, historically, the aim was to get the pregnancy to 36 weeks if there was no evidence of infection. However, with improvements in neonatal care and evidence for poor outcomes in babies if there is a maternal infection, management has shifted toward 34 weeks and induction of labor once there has been a course of steroids. With preterm premature rupture of membrane, PPROM, if there is no concern for developing infection and there are no signs of labor, it may be possible to continue conservative management at home. And also, we can prescribe a course of antibiotics such as clindamycin and penicillin during labor if it is more than 36 weeks. Okay. And if GBS is group B streptococcus is isolated. Okay. Similarly, we can prescribe prophylactic erythromycin 250 milligram 4 times a day for 10 days in case if it is between 34 to 37 weeks of gestation. Okay. And we can during labor we can prescribe clindamycin and penicillin combination. Okay. And we can also prescribe corticosteroid if between 34 and 34 plus 6 if it is between 34 and 36 weeks gestation. Okay. We can prescribe corticosteroids if because there is a risk of lung immaturity, so we can prescribe corticosteroids if it is between 34 to 36 weeks. Okay. And we can also induction of induced labor. Okay. If the pregnancy duration is less than 33 weeks, or if it is between 24 to 33 weeks, we need to monitor for signs of clinical chorioamnitis, the infection, and advise patient to avoid sexual intercourse. We can also prescribe prophylactic erythromycin 250 milligram 4 times a day for 10 days. Okay. And also we need to prescribe corticosteroids, and we can aim to for expectant management until 34 weeks. Okay. So sometimes this premature rupture of membranes can be very early, so that can be dangerous to the baby and mother also. Okay. Because of these complications which I am going to tell you. Okay. So in the complication of the majority of the women at if there are near term will enter spontaneous labor once there is a premature rupture. Usually within 24 hours, but there is a greater latency period the younger the gestational age. This predisposes to the greater risk of maternal and fetal complications. The first is amniotic, which is inflammation of the fetal membrane due to infection. The risk increases the longer the membranes remain ruptured and baby undelivered. Then there's the chance of oligoarrhythmias. This is particularly significant if gestational age is less than 24 weeks, as it greatly increases the risk of lung hypoplasia. And on this channel, I have already uploaded a video about oligoarrhythmias just few days back, and you can watch that video. That is also very informative video. Okay. Also, there's a risk of neonatal death due to the complications associated with prematurity, sepsis, and pulmonary hypoplasia. Also, placental abrasion can take place, which is a separation of the placenta partially or completely from the wall of uterus. That cannot be also be dangerous. There's a video about placental abrasion on this channel that is very informative. You can see that video also. The link will appear in the I button. Also, there is a chance that umbilical cord prolapse can take place, which is another serious emergency. Okay, so these were the complications. I hope you like this video. If you have any question about premature rupture of membranes, you can post in the comment section and I'll try to reply to your question as soon as possible. There are so many videos on this channel about different medical illnesses, and if you or your loved one is suffering from any illness for which you can't find the video on this channel, you can post a comment, and if I find a time, I'll try to make a video about that particular illness. Thank you very much for watching this video. See you in next video. Bye for now.